Based on these data, would you move to Ponatinib frontline?
I mean, based on Martinelli's data and then his data from MD Anderson using hyper-CVAD plus Ponatinib, I would consider changing from dasatinib to Ponatinib. My only concern is, as we treat more patients with Ponatinib, are we going to get more vascular complications? And I think one way of overcoming that is to start with 45 milligrams, and then after one cycle, bring the dose down to 30 and 15, and not keep patients at 45 continuously.
My big concern is what to do after the Ponatinib. And that continues to be my concern. So I'm one of those stalwarts. I'm still a dasatinib or a Sprycel, hyper-CVAD induction. Try to get as much mileage as I can out of the second generation TKI. If I fail to achieve a good molecular endpoint with my TKI in preparation for allo, that's when I'll consider moving to the Ponatinib almost as a bridge to try and get them there. But I've just been concerned that if I use up my options, the initial data with Ponatinib, and again, it was a combination of CML blast phase and as well as some ALLs in the New England Journal paper. But it was a median remission duration, I think, of around 6 to 9 months, if I recall, and that bears clinically with what I see in most of my patients. I don't want to use it up. I don't want to take that. I'm still very just apprehensive about taking that risk.
I agree, Bijal. I take the same sort of approach, and I also agree with your point, Anthony, about the low intensity strategies for these patients that we're trying to get into the deepest remission possible. I mean, from at least in my practice, and you guys can certainly disagree with me if you see differently, the patient that is diagnosed with ALL that is truly unfit for intense chemotherapy is generally pretty infrequent. I mean, this is a disease of younger people, while Ph positive is relatively more common in older patients. I don't really see too many patients that I really don't think I could give some form of chemotherapy to. And I think the other practical implication about trying to use Ponatinib in the frontline setting is that the fact that it's only approved for relapsed refractory ALL. So while the studies are ongoing and may be able to change how we're able to prescribe it, right now there may be some challenges outside the context of a clinical trial unless a patient wants to pay for it out of pocket.
And I would say that although I used to agree with your sentiment about kind of saving the Ponatinib in case they fail a second generation TKI, I'm now kind of reluctant to pull that punch because I think we have options for relapsed refractory, even Ph positive ALL, with some of the newer agents that have activity in that disease. So you may not necessarily need to rely on the Ponatinib to get them back into remission. And I think that you have one best shot on goal to get your newly diagnosed ALL patient into the best remission and to minimize the complications that they'll have from therapy. So at this point, I think my opinion is that whenever it's permissible with the payer, I'd love to add the Ponatinib up front and get that best response.
That's an interesting point. I think we don't know for sure whether dasatinib or even Ponatinib is truly better, but I think most of us, certainly my standard has been to use dasatinib. Another quick question on this before we switch over to Ph negative is when would you do mutation analysis for the BCR-ABL gene? Do you do it at diagnosis or when they start to fail, or?
I don't. I typically reserve that for a time after recurrence or persistence of disease. It's not something that I'm routinely doing at the time of diagnosis.
And usually you have to have more than very low MRD levels of disease in order to do an ABL kinase domain mutational analysis. So usually it's at very early relapse that you're going to have the opportunity to do that.
Just the last thing I'll mention when Ph positive ALL is there's an interesting abstract at this meeting, the ASH meeting, of combining inotuzumab with bosutinib. So sort of a novel combination. This is in relapsed refractory patients, but they saw, as anticipated, a nice response rate. So we've got lots of options for Ph positive ALL these days, and it's really been very encouraging to see.